Okay, well, we're going to get started. The first thing I want to do is let people know about the Thomas A. Neff Lecture Series. So this talks about the career of Tom Neff. He was one of the pulmonary critical care attendings down at Denver Health. He unfortunately passed away at the age of 57 in 1994 when I was a fellow here that long ago. He was really a remarkable person. I don't think there are people like Tom, that many left in medicine anymore. He was the consummate physician educator. He knew everything about pulmonary medicine, and his career was really devoted towards educating the next generation of learners. He was really a remarkable person and part of the heyday of our division, where we had very prominent people, as we still do, at each of the 4 sites. One of the stories I like the most about Tom Neff is he grew up in a small town in Nebraska, in Fremont, Nebraska, and he played football there. And the interesting story is he was the quarterback. And for those of you who know who Mike Eisman was, again, one of our famous pulmonary physicians who specialized in tuberculosis. Mike Eisman was actually the wide receiver on the football team. So there was a long time connection. This lecture series is in Tom's honor, and you can see here, we've been fortunate to invite many very distinguished and esteemed speakers to give the Neff lecture. This is, if you want to request CME, please scan the QR code. And the second thing I have to do is I have the honor to introduce Nadia Hansel, who is the interim director of the Department of Medicine and the physician-in-chief at Johns Hopkins. Nadia has a very distinguished academic pedigree. She went to Harvard and then stayed at Harvard for medical school. She then moved a little bit south to Philadelphia and did her residency or internship and residency at the Hospital of the University of Pennsylvania, which I'm psyched about because that's where I did it also, a little bit before Nadia. And then she kept moving south and went to Johns Hopkins for her pulmonary critical care fellowship and stayed there. And as we say, rose to the ranks very quickly. She's had a very distinguished career. She was elected to the ASCI in 2021. She's published over 260 papers in very prestigious journals, New England Journal of Medicine, JAMA, Internal Medicine, and the American Journal of Respiratory and Critical Care Medicine. She's also had continuous NIH funding since 2004, which is approaching 20 years. And don't take that lightly. That is not an easy thing to do, to have continuous NIH funding for that period of time. She also is an amazing educator and has trained multiple investigators that now have their own career development awards or R01 grants. And her area of expertise is the impact of the environment on chronic lung diseases such as asthma and COPD. So we're very honored to have Nadia here to give the Neff lecture.
Mark, thank you so much. First of all, I just have to say how impressed I am that you remember all of those things, because now that I have to introduce people more often, I always have something that I'm reading from because I'm afraid I'm going to mess up and not say things right. So that was just actually impressive. And the list of former speakers for the Neff lecture, I'm just absolutely honored to be standing here today and speaking with you. I really look forward to today, to tomorrow. I had a fabulous time yesterday meeting with old friends and faculty. You have an amazing group of faculty here at the University of Colorado. And so thank you very much for the invitation. So yes, I'm going to talk a little bit about my research, understanding environmental and social determinants of health and how that might contribute to health disparities. My career started off mostly thinking about asthma and genetics of asthma. And then I sort of jumped ship a little bit and have been focusing more on environmental health. And if there is time at the end, we'll just give a shout out to some of my mentors that supported me along the way in terms of my career choices and even changing sort of my career direction a little bit and making me realize that it's okay to do that. I really don't have financial disclosures that are relevant to this talk, except for donation of Austin air cleaners, which I will mention as a clinical trial that we just completed. So really, the guiding light in everything that we do in medicine always comes back to the patient. And for me, it were the patients that I saw that made me question and be curious about why some things were happening. And this is one of those patients that I actually have been seeing for 20 years since I was a fellow at Johns Hopkins, and then only recently passed away about 1 year ago. And I was always intrigued because she was 68 years old and she actually never qualified for any of the COPD studies because she hadn't smoked enough, right? She said, well, when I was 18 to maybe 24, I smoked about a pack a day and then I quit. I haven't smoked since. She did have parents who smoked, but otherwise really had no other reasons that I could identify for why she had emphysema. And as you can see from her spirometry, for those that are used to looking at spirograms, I mean, she was going 15 seconds and the air was still blowing. And she really had a FEV1 of, I don't know why I have timer on this. I didn't plan that. But anyway, very severe obstruction, again, with very minimal smoking exposure. So it was this patient, and I sent her for alpha-1 antitrypsin deficiency testing actually twice, just in case there was an error the first time. I was convinced she had some underlying genetic reason for why she had such severe emphysema, and she might have. She really did not want to share blood for other rare variant testing or anything else. And so I don't know whether she had other genetic etiologies, but really I was kept being curious as to why she had such minimal smoking history and very severe disease. And yet, and I hear it a lot, when you go into the community or you're treating a patient with COPD, you often hear even pulmonologists saying, well, they just need to quit smoking. And nothing in my talk wants to minimize the importance of cigarette smoking. Cigarette smoking clearly in the United States is the #1 driver of disease development. And we really, really need to encourage people to quit smoking if they are. But what I was really curious about is, even if someone quits smoking, why do they still potentially progress? As in this patient, she had quit smoking at the age of 24, but as I was following her over those 2 decades, her spirometry continued to worsen. So I really became intrigued by why our understanding of these contributing risk factors for COPD, despite our recognition that biomass in developing countries and smoking in the United States drive the disease, of why 15 to 20% of smokers still develop COPD. 1 out of 4 Americans never smoked cigarettes. And if you look at large-scale studies, the variability in FEV1 or lung function is really only explained about 15% by cigarettes. And that's probably due because we don't really quantify cigarette intake very well beyond pack years, which is such a crude measure. But even our GWAS studies and other genetic studies absolutely showed genetic risk contributions, but they still only explain a small proportion of risk. So clearly, if you go to our guidelines, there are some shout outs to other exposures that contribute to disease, right? So the GOLD guidelines, which are our national guidelines for COPD, do comment on occupational exposures, including organic and inorganic dust, chemical agents, fumes, are underappreciated risk factors for COPD. The ATS came out and said that approximately 20% of our cases of COPD are attributed to workplace exposures. And then a lot of the work, which some of you may be familiar with, the Spiromics, which is a multi-center cohort, because Russ Bowler at National Jewish and James Crapo and many of the faculty here have been instrumental in launching of that study in addition to COPD gene. But we did look at very extensive occupational history questionnaires and created a job exposure matrix and found that 38% of folks enrolled of the 3,000 smokers with lung disease, that 38% of them actually reported workplace exposure in addition. And this cohort had a 20-pack year minimum criteria of smoking history for entry into the study. So for all intents and purposes, these were actually pretty heavy smokers. But despite the heavy smoking history, if they reported that they had a job that exposed them to vapors, dust, gases, or fumes, or this more explicit job exposure matrix that we had done, there was a 44% increased risk that they had spirometric airways obstruction. And together with Laura Paulin, who's now an assistant professor at Dartmouth, we really looked, and we'll, through my talk, you'll see a lot of these measures that we look at. 6-minute walk distance in terms of functional status, how far people can walk in 6 minutes. The MMRC is our dyspnea scale. PAT is a measure of respiratory symptoms health status. SGRQ is a respiratory specific quality of life, just in case there are folks in the audience not familiar with those measures. Percent emphysema on a CT scan, airway wall thickness on a CT scan, how often do you need to go to the hospital because you have exacerbation? Like across a myriad of morbidity measures among those that have COPD, if you also had occupational exposure, you were worse off. So when you go to the clinic and someone says, how much do you smoke? You're not capturing all of it. And a lot of the work that I have spent over the last 15 years is trying to understand, even beyond occupational exposures, what other contributions are there to disease. So I'm not going to define particulate matter so much here for this audience. I'm sure you're very familiar. There's been a lot of studies that looked at outdoor air pollution and how ambient particulate matter, or PM, is linked to lung disease, either lung function, COPD, risk, hospitalization for COPD. It's not surprising when you look at skyline pictures that on higher pollution days that inhaling this type of worse air quality could be detrimental to your health. And you don't have to live in developing countries to be exposed to what we would think of as worse air pollution days. But the question that I was really curious about also wanted to extend beyond those gold guidelines, which really still, even today, focus primarily on the burning of wood and other biomass fuels used for cooking and heating in poorly vented dwellings is a risk factor that particularly affects women in developing countries. Reduction of exposure to smoke for biomass fuel is a crucial goal to reduce the prevalence of COPD worldwide. Very little attention to saying what is the effect of air pollution, indoor, even outdoor air pollution here in the United States. So 10 years ago is where I published probably one of the first studies that looked at indoor air quality for COPD. There had been studies looking at indoor air quality as a risk factor for asthma or for worsening asthma morbidity, much less done in COPD. Again, I think probably because people just really attributed COPD here in the US to smoke. Even though the indoor PM levels on average were really low in these homes, because we actually recruited 75 patients with COPD that had already quit smoking. Because when I started this, I thought, well, if you do smoke, actually, then you're just going to outweigh any effect of these environmental exposures. So I purposely recruited only people who had quit smoking. The indoor PM levels varied between 0 and 100, but the average was pretty low, just at 12. But what we did see, and we followed people over 6 months, and we measured air pollution in their homes at baseline 3 months later, 6 months later, and we saw that when things varied and when levels were higher, patients were more likely to go to the hospital for exacerbation risk and have worse respiratory symptoms, worse quality of life, and they were reaching for their inhalers more often. So even in what we consider relatively good air quality or low air pollution homes, don't use biomass. In those with chronic lung disease, we think exposures matter. And the pollutant burden in our US homes are actually worse in many areas than they are outdoors, right? So the EPA will tell you, hey, it's a high air pollution day, stay inside. But that is taken completely out of context as to what the indoor environment is. And when you go to inner city Baltimore or Baltimore City, if you look at that graph, you can see that the indoor pollution, and we measured outdoor monitors right outside that patient's home on exactly the same week, the indoor, for the most part, was worse. And this study was done, the EPA level is that dotted line, what was recommended for outdoor. It's actually more stringent now. We even say it shouldn't be higher than 12 for PM 2.5, but you can see in our homes, again, similar to our COPD homes, the levels ranged quite high and were usually higher than the outdoor air. The sources are smoking in the house. In Baltimore City, a lot of people like to burn candles or incense. They're cooking without ventilation. A lot of our row homes don't have attached garages, but if there are attached garages, we can show that attached garages with cars that could create fumes indoors. fireplaces, sources of heating, all are contributing to that indoor air quality. Opening your window, actually, can expect, looking at these gradients of pollution, if every 10 minutes of window opening was associated with better indoor air quality. So staying indoors could be, for some people, a bad recommendation. So these were kids with asthma. And then we did repeat studies. These are two separate cohort studies of patients with COPD. And it's not as remarkable, but we see the same type of gradient that many indoor homes have much worse air quality than the simultaneous concurrently measured ambient outdoor pollution measures in the outdoor right outside that participant home. The left side is another 120 homes that we did in urban Baltimore City. And then the right side was a study that we were doing in Tennessee in a rural area called Johnson City, because we wanted to understand the differences between urban or potentially rural pollution. And similarly, in rural Tennessee, you can see that the indoor air levels in many regards were worse, and two values we didn't even plot because they were way off our charts. They were so high in terms of poor indoor air quality. And we don't do great work at all to understand whether different types of pollution or particulates are better or worse for lung health. And clearly, the exposures and the factors contributing to these very high indoor pollution levels in rural areas could be different, because there's trash burning, there's burning of wood, these things that we think about in developing countries, but we have to remember there are areas in the US that continue to use them. So that same study that we published a decade ago from urban Baltimore that I said, well, when the air pollution is worse, people are more likely to go to a hospital and more likely to have wheezing and respiratory symptoms. We repeated a similar cohort in that rural Tennessee cohort. This was only 50 patients. You would think 50 patients is not adequate power, but you could see we had a lot of statistical significance here with only 50 participants followed over 6 months. That when indoor air quality was worse, they were more likely to be short of breath, report worse respiratory quality of life, and even sort of rhinitis symptoms, itchy, burning nose, and from the rhinitis quality, I forget what the RCAT actually stands for, but the rhinitis questionnaire. So again, much more symptomatic with worsening indoor air quality. I am not a translational person, but we did want to try to think about biomarkers of exposure. So this is induced sputum samples where we actually looked at macrophages that we isolated from induced sputum samples. These again are not people who are currently smoking, but you could see that there are macrophages that get these black carbon content depositions, and we found a very strong association, not with ambient pollution, but with the indoor air quality that we measured in their home. Those folks tended to have much higher burden of this black carbon deposition in their airway macrophages. And again, these are COPD patients. They actually report on average spending 20 to 22 hours inside their house. Because they're chronic lung disease, they don't have that much mobility. So these patients spend an enormous amount of time inside their house. And so you can imagine that makes sense, that indoor environment is particularly important. And so we also showed that if you just look at the biomarker of this black carbon content in the macrophages, it was associated with their likelihood also of having exacerbation over the next 6 months follow-up. We then, with a fellow with me at the time, who's now at the Cleveland Clinic, Dr. Tejwani, looked at this in the spiromics cohort across 300 induced sputum samples, where we looked at that similar black carbon area. And you can see, again, in a much larger national cohort, that black carbon content in former smokers isolated from the sputum was associated with future exacerbation risk, worse lung function, and other outcomes. And so I do think that this is potentially a biological marker of exposure that's linked with worse outcomes, and sort of how these affect the macrophage and how it might affect macrophage dysfunction, I think is something left to be determined. So these studies are really short-term studies over 6 months, looking at a patient with disease and whether fluctuations in indoor air quality are associated with worsening symptoms. The question I had in posing is, can these indoor exposures in US homes with relatively pretty good air quality linked with lung function decline? Or can it contribute to the development of disease? I don't fully know the answer to this. This is actually, I say, estimated indoor PM, because up until recently, the monitors for measuring indoor air quality were pretty labor intensive, right? You got to plug them in, you got to drop them, set them up for the participant, you got to pick them up. So we have all these folks that work with me that drive to people's homes in Baltimore City. Unfortunately, one of our folks just got in a car crash. That's not cool, but we work really hard to go to people's homes and to actually measure the air quality. Now there's actually low-cost sensors that you can actually potentially mail to people to get better long-term measurements of indoor air pollution, and we would like to do that moving forward. But we did a validation study as part of Spiromics in 200 homes where we went and we measured the indoor air quality and then did a slew of questionnaires to see if we could match the questionnaires with what we measured. And we determined that we could estimate about 60% of the variability of indoor PM based on questionnaire. So it's still a bit crude, but we did across 1,800 people in Spiromics, that heavy smokers, former smokers across the US as part of Spiromics, give this questionnaire to estimate their indoor PM. So this is questionnaire based this time. This is not actually measured, but say we estimated the indoor PM based on questions and based on outdoor EPA measurements, infiltration estimates as how much of the outdoor air goes inside, what are the indoor sources, do you have a fireplace, how often do you use a fireplace, do you smoke, does anyone smoke in the house, do you cook in your house, does your stove or oven have an exhaust, a ventilation? Do you use the ventilation? Do you have an air purifier in the home? So it was a pretty extensive questionnaire to try to estimate. And we said we can estimate about 60%. If you look at that cohort that are actively smoking, the estimated indoor PM in their house didn't seem to make a difference, right? They had accelerated loss of lung function at about 60 cc's a year. And if you look at studies like the Lung Health study or longitudinal cohort studies that have been done historically, we do think that current smokers, like non-smokers, lose about 30 cc's of lung function. And then if you're actively smoking, it probably doubles to about 60 to 80 cc's. Depending on the cohort, there's a little bit of variability in estimate. But this is right around the ballpark of what we've seen in other long-term longitudinal studies, that current active smokers lose about 60 cc's of lung function, and your indoor air quality in your house didn't really matter. What was interesting is we looked at people who quit smoking, and all of a sudden we saw a different picture. If you quit smoking and you lived on the left in a home that had better air quality, your rate of lung function decline went back to that of a non-smoker, about 24 cc's a year. If, however, you quit smoking, but you lived in a house that, based on questionnaires at least, we estimated that you had higher or worse indoor PM, you continued to have lung function decline as if you were still actively smoking. So my question is, can where someone lives, can the air quality inside their home explain some of this variability in lung function loss that we see in smokers who quit smoking? I think it's provocative. I acknowledge the limitation that this is questionnaire based, and I think it begs the question about, should we be measuring the indoor air quality in people's homes to confirm this data? And I would love to see that study be done. I think it's necessary. I think this is actually modifiable, right? It's really hard to tell someone, even though we did it for COVID, to wear a mask every time you're outside the house on air pollution days. We know that telling someone on a high pollution days to stay inside and close your windows could be actually bad advice. But what do we tell someone to do when they're inside their house? Right now, we don't tell anyone to do anything. Like, there is nothing in our guidelines that say, hey, let's measure indoor air quality. Let's get that to a low level. So this is where I think there is an absolute gap in our guidelines. And I think that this is an opportunity for us to think about whether there's an opportunity to guide further approaches to improve our lung health. So I want to move to something I've been working on with our team a little bit over the last couple of years, is to actually, I spent a lot of time focused on this indoor air pollution. But are there factors beyond pollution that affect lung health? And something that has quite bothered me in epidemiological studies is that we adjust for socioeconomic status with income and education. And in my papers included, we say we've adjusted for socioeconomic status. Is that enough? We know that COPD prevalence is worse in low-income areas. Low-income areas have higher smoking prevalence, but if you adjust or account for the higher smoking prevalence, they still have higher COPD rates, right? So if you look at a map of the US, there are pockets where COPD prevalence is really bad, and they are primarily in low-income areas. So this is from our spiromic study. This is not really published, but we looked at what they report as individual household income on the x-axis. And then we said, where do they live and what's the neighborhood income, the median household neighborhood income? And I was quite shocked with that amount of variability, right? So you can have someone whose household makes greater than $80,000 a year, who still decides to live in a relatively what we could call a higher poverty neighborhood, or they live in a better neighborhood. And on the other side, people that have low family income that still have quite a bit of variability as to where they live. There's a lot of reasons why people choose to live where they live. Some people stretch their means, some people don't. And so there's a lot of variability. And so the question that I posed is, does the individual income that we adjust, is that adequate to address for socioeconomic status in our studies with COPD? And I think the answer is no. So here we look at individual socioeconomic status that we've adjusted for in every single COPD gene or spiromic study, whether the participants' education and their household income. We adjusted for whether they said they smoked, for their pack years. We adjusted for that occupational exposure that I already said has been associated with outcomes. We adjusted for whether they lived in an urban area or rural area, and their neighborhood deprivation, this was measured by a neighborhood area deprivation index, was associated, again, with worse outcomes across the slew of morbidity measures that we tend to use in COPD studies. When we also adjusted for ambient pollution levels in sensitivity analysis, which I don't show here, these results were slightly attenuated but persisted and were still statistically significant. So I think pollution is one explanation for why living in a low socioeconomic neighborhood might have adverse consequences, but it's not the entire story. And neither is someone's reported personal income. So the question is, what about lower socioeconomic status neighborhoods might be driving some of these disparities? I think it's complex. I don't think it's one answer, right? But we did, our group for a story I won't get into, got very interested into nutrition, something that I did not anticipate. I don't have a nutrition background, but I'm excited to work with some of my nutrition epidemiology colleagues. But we looked, there's a lot of areas in the US that are considered low food access areas, like you just are not close to a healthy grocery store. And we did find that if you lived in a low food access area, you also had worse COPD outcomes. And not just self-reported outcomes like shortness of breath or quality of life, but you actually had were more likely to have lower lung function and higher emphysema on your CT scan and higher evidence or odds of COPD, of obstructive airways disease. So you might ask, why would living in a low food access area matter? Clearly, in my mind, the driving hypothesis is that, well, if you don't have access to healthy foods, then you're less likely to have a healthy quality diet. Because of a study that we focused on looking at omega-3 fatty acid as sort of anti-inflammatory, there's a lot of cool work in asthma suggesting that high omega-3 fatty acid intake could be anti-inflammatory or healthy in this case, eating sort of the fishes and the other EPA, DHA contributing fatty acids. We did look in our cohort to say, well, based on food frequency questionnaire, if you lived in a low food access area, were you having the same quality diet, in this case measured as omega-3, and you weren't, right? So if you were not close to a healthy grocery store, you were less likely to have EPA or DHA intake. We did this both by food frequency questionnaire, but we also did this by plasma levels, again, trying to get out of reporting biases towards objective measures. And then the question was, well, do these omega fatty acids matter in COPD? And we did, again, this was cross-sectional, so you got to take that with a grain of salt. We cannot fully talk about causality here, but there definitely was an association. And if you look at omega-3, which is in blue, again, that's the more healthy fatty acid, you can see that as your intake increases, you go from left to right. The CAT score, the SGR score decreases. Those are better scores, and your exacerbation risk decreases. So there was a cross-sectional association that if you have a higher omega-3 intake, you have better sort of respiratory measures. Again, it's not, we can't go with causality here, but again, I think it's provocative about whether dietary measures can play a role in lung health for COPD. And again, because I'm not arguing that it's one story, the same way I don't think it's only smoking, even though that's the biggest driver. I think there are other drivers, and I don't think they act independently to make the story even more complicated. So we had a study to look at sort of these interactions or co-exposures. I'm not going to focus on all of them. I'm just going to focus on one that we recently published. So ozone gets a lot less attention compared to particulate matter and outdoor air. But we did publish, and this was also shown in MESA by Joel Kaufman at the University of Washington team, that ambient ozone is associated with like worse emphysema. We also showed that in spiromics, that if you lived in an area with higher ozone, you were more likely to have worse emphysema. You were also more likely to have COPD respiratory symptoms and lower functional status. I want to make the note, this is Dan Bells, he's now a junior faculty at Hopkins with me, did this as a fellow. The ozone effects were not universally distributed. So if you look at the black bars for a second in a low poverty neighborhood, if that low poverty neighborhood had higher ozone, it didn't seem to be that bad for you. It was when you lived in a high poverty neighborhood and you were exposed to ozone that the ozone seemed to be most detrimental. So even when we look at these large scale association studies and we look at what is the effect of exposure across an entire group, I still think that there is probably a group that is more vulnerable that we often don't realize the higher vulnerability that some people face to ambient pollution exposure or other exposures. And again, this was across the board for several outcomes that it was pretty consistent that this interaction effect. So many factors coalesce to affect respiratory health. You go back, let's just take a patient example. A 60-year-old white male smoked for 20 years, 1 pack per day. Now you take that exact same patient, 20 pack years of smoking, but he also works in a dusty job. He also has a wife who smokes in the home. And he happens to live in a neighborhood that's a high poverty neighborhood. There's not a grocery store nearby, and it's a high ozone area. You compare that man with only the smoking history to the man that has the smoking history plus other factors often out of his control. And he is expected, based on the modeling, to have almost a 20% lower percent predicted FEV1. That is highly clinically significant, right? And a 7-point difference in CAT score, and just the MCID for our CAT score is 2. And so I encourage us to think about the patient that comes into your office who smoked with COPD or bad emphysema. And absolutely, again, none of this is discounting the importance that he has to quit smoking. But I encourage us to take a little bit more sympathy to some patients, that there are many factors that affect their outcome that could be out of their control. And it's our job, I think, as healthcare providers to think about some of those factors and see, can we impact them further? Do I think, and I talked mostly about socioeconomic disparities, do I think some of these factors can explain racial disparities in COPD? This was work I did with Dr. Ejike, who is also a pulmonary fellow with me. When we looked at this spiromics cohort, there were about 529 that self-identified as Black and 2,000 or so that self-identified as white. I excluded other races for this comparison. And Black participants were more likely to report worse or to have lower functional status or higher exacerbations in the last year across the cohort comparisons. When you look at what we traditionally adjust for in our epidemiological studies of education, self-reported education of income to say we accounted for socioeconomic status, you can see that some of the racial disparity is attenuated. Most of these, except for the MMRC, which is dyspnea, are still statistically significant. And now we also adjusted for those neighborhood. Where does that participant live? And you can see that there is further attenuation. And 3 of the 5 outcomes here are no longer statistically significant. So I would say that we are missing some factors that contribute to racial disparity if we only look at self-reported income. The other thing I want to mention is that I don't even think looking at economy of a neighborhood is adequate. So racial or historical redlining was from the 1930s, where the mortgage lenders categorized neighborhoods into low risk or high risk for mortgage and loans. And unfortunately, at the time, used race and the proportion of Black or other minorities living in the neighborhood to add to the risk that they identified for that neighborhood, automatically putting that neighborhood at risk of less investment and less ability for home ownership. That was outlawed back in the 1960s. However, the impact of that still resides with us today. So this was great work done by Sally Wenzel, which I know many of you know, that looked at Pittsburgh. And on the right, you just show pollution levels in those areas that were deemed affected by this historical redlining. And you can see that as it goes from low risk at the time from the 1930s to 60s for mortgage to D, high risk, you can see that those areas, even today in 2020, still have higher pollution levels. They did a great job in this article also linking that to asthma morbidity. So we similarly looked at this in COPD in our spiromics cohort. And again, so Sally Wenzel's study showed a great job about linking to higher pollution sources, but these neighborhoods in other studies has also been shown to have lower socioeconomic status or just economy, like household income. They have worse housing quality. They have poor quality schools. They have poor healthcare to access. They lack full service grocery stores. They lack safe and healthy parks. They lack reliable transportation. There are differential access to employment opportunities. There's higher crime and violence. So it's very complicated. But we looked at our spiromics cohort. We looked both at the Black and the white participants in our study. Here we showed if you are Black and you live in a highly segregated area, we're adjusting again for smoking, individual socioeconomic status, your occupational exposure, the economy of the neighborhood, the poverty rate, the household income, unemployment rate, educational attainment. And you live in a segregated area across the board for all of our outcomes, including objective outcomes of emphysema, air trapping, they were less healthy. This is an action to us that there is something that we need to do about this. When I go back, and this is unpublished at this time, but when we published the initial paper, we did it just on the socioeconomic status. If I add the disparities, if you're living in a segregated neighborhood, many of these racial disparities attenuate almost completely. Not all, but many. So what can we do? So a lot of the work has been observational. They identify the problem, they don't identify the solutions. A lot of the solutions require not just healthcare, they require policy change. I did look, so if you take the spiromics cohort, there's 3 years of follow-up. There is higher mobility in Blacks compared to whites, but in that 3 year of follow-up and already a population that's about 60 years old on average, 22% of Blacks and 10% of whites moved during the 3 year follow-up. If moved to a neighborhood that was 20% less segregation, there was an improvement in some outcomes. The difference between Blacks and whites was 51 to 4%. So if you could have a 1.6 change in CAT score, 3.1 difference in SGRQ, those are really about the MCID of 2 or 4 for those measures. So there is opportunity, I think, for not asking people to move, but are there interventions that we can do at a neighborhood level to improve the quality of life and health of those residing in those neighborhoods? A study that we recently published focused on indoor air quality. One of the things that excites me about studying the indoor environment is actually something that you can potentially provide individual recommendations for improvement. So we, over 6 months, gave participants 2 air cleaners that either had the air filters removed or in the filter. So there was a sham versus an active group, and they were told to run continuously for 6 months. The good news is that we were able to reduce pollution. That's in orange. That was the active group that had the active filter. You could see that there was a 30 to 58% reduction in pollution. We looked at both NO2 and PM. I will say these filters had high carbon, 15 pounds of carbon filter in them that are sought to absorb gases. The HEPA filter is what removes the particles. I do think most of this is particle removal more so than NO2 removal is probably beneficial, but there was also some NO2 reduction as these were specifically fitted to hopefully absorb gas. So our primary outcome was SGRQ. You can see we missed our primary outcome for the study, right? So there was a 1.6% decrease in SGRQ in the treatment group compared to the sham group. If you look at symptoms per se, there was actually a statistically significant difference, but that's a subscale of the overall total score. What I think is fascinating, if you looked at adherence, right? So we tell people to turn on the air cleaner, but if they actually turn on the air cleaner for 80% of that 6 months or turn it on for the entire 6-month period, you can see a dose response, right? It's like a medication. If you don't take it, just putting an air cleaner in the house, we've learned this from our global health studies, right? You can't just swap out the stove. They've got to change their cooking habits. It's the same thing with an air cleaner. You can't just put the air cleaner in the house. If they don't use it, you're not going to get a health impact. But the more they used it, you could see the difference by treatment group. And there was no difference in usage here between the active group and the sham group. So I do think that we were well blinded. We had about 70% of the cohort with 80% adherence, and we had about 40% of the cohort with 100% adherence. But you can see a nice dose response, which I think does truly suggest potential treatment, possible benefit of air cleaners. The other thing is if I look at secondary outcomes, rescue medication use or moderate exacerbations were statistically significant in all comers, even without sort of subgrouping on adherence. So we missed our primary outcome, but we see a dose response, and we actually found statistical significance in secondary outcomes. Currently have a NIH grant to do a much larger multi-scale study of an air cleaner intervention trial. We'll see how it goes. But really, I want to impact guidelines. I want us to change what we do. And I think a 100-person or 150-person study in Baltimore City just is not going to cut it, right? I think I need that multi-center study to show that this needs to be put in guidelines, because if we do this broadly, we can impact change or we can improve health. And it's an environmental intervention. There's hopefully no side effects like we have with steroids or other factors. And almost every time I present these results or suggestion about an air cleaner study, I get, what about the cost? Nobody asks about the cost of medicines, right? But all of a sudden it's an environmental intervention. It's how much does it cost? What I will show you is, medicines cost money, actually more money than actually the air cleaner does, right? So you just take, this was done for an asthma comparison. So I know we don't use montelukast or omalizumab for COPD, but regardless, the cost of biologics is high. The cost of inhalers, if you have patients that can't pay their copay, you realize they're high. Portable air cleaners are like $500, $600, maybe. You can even get some that are cheaper for $200. And then the cost of running them is like running a light bulb in your house, right? So I actually think if we get health benefits, the cost is ultimately potentially lower than what it would be for medications. And I think some of our health effects, impacts could be similar to some of what we get with inhaler use. Anyway, I do think it needs a larger scale multi-center trial. So for all those that believe in something that everyone else poo-poos, this is a current R01 that is delayed with wrapping up just because of COVID, but we're almost finished recruitment. We'll be finished recruiting in the next 6 months. Everyone told me it was a dumb idea to repeat sort of this clean air study among smokers, to like, you just need to quit smoking. A, and B, we'll just extrapolate your study from former smokers. I kept saying, well, you can't just extrapolate from former smokers because of exactly what you just told me. They just need to quit smoking. That's exactly what everybody says. So you miss an opportunity for harm reduction, right? If you only tell someone they have to quit smoking and you don't say, well, you could also do X, Y, and Z while you're working on quitting smoking because we still want them to do that, then you're missing an opportunity for harm reduction. And I was personally convinced that unless we showed that an air cleaner intervention study can work in active smokers, I'm always going to be left with it. People just don't do it. And so this study, we'll see the results. Everyone told me it was a dumb idea, even the program officer. But I submitted the grant and it got funded. So all of you who, and I was talking to someone, Sarah, I think yesterday, where I was like, well, you know, if you're looking for funding and you're about to go into GAP, don't take the high risk idea. But, you know, if you really believe in something and you have an opportunity, it's still worthwhile, I think. I believed in the need to do it. And so we'll see what the results show. Indoor NO2, let me check the time quick. I don't want to have a little bit of time for questions. I'll just say gas stove use can be a big driver of NO2, and in homes, you can get really high levels of NO2 inside homes if folks are using gas stoves. We did do an intervention study where we did some ventilation, air purifiers. If you take out a gas stove, you put an electric stove, you can reduce by about 50% NO2 levels. I'm not going to talk so much about the ventilation hood. That did not work in this study, but I do think it works. It just didn't work in this study. Whether this is linked to potential health benefit is unknown. In our air cleaner trial, we tried to address that statistically, where we looked at whether the air cleaners reduced NO2 or whether it reduced PM. And we published that separately, but I do believe it was the PM reduction that was linked to health benefits in our COPD study, not the NO2 reduction. But I do think this is another potential target. But if we're going to try to prioritize, I would sort of move towards trying to reduce indoor PM. I just want to end with a couple slides. The food access issues, again, here is where a career is a journey. I did not have any interest in nutrition, but my work led me to this interest in sort of food access and food quality. There are a lot of areas in red here that are considered food deserts, right, in Baltimore City, right? There's just no access to healthy food. So NHLBI, thankfully, has funded a study that we recently launched. We called it the Omega COPD trial. It is trying to address this issue. So we're recruiting 200 former smokers that have low omega-3 intake, which is almost everybody, honestly. We have like 8 in 10 participants that have low omega-3 intake. So almost everybody qualifies from an omega-3 intake level. And we are partnering with Amazon Fresh. We are delivering food with high omega-3 intake to those homes. Sadly, even Amazon Fresh leaves some of the most vulnerable people underserved. 10% of the people that we enroll, I can't even get Amazon Fresh to deliver to their house. So right now, we are probably, as soon as I can get the resources, going to have some of our home drivers actually do the weekly delivery so that we can get folks the healthy foods to their house. So the goal here is to think that if I can actually get someone healthy food, and again, I really recognize you just can't hand deliver it. They've got to eat it. We are also working with behavioral psychologists to call weekly to help them talk through preparing the foods. Why didn't you eat the food? How can we help you? So problem solving to get them to encourage them to eat it. So it's partnered with the food delivery, which addresses the low food access issues. The healthy food and the motivational coach is going to try to address the behavioral issues. And we're paying for the food. They get $50. So that's going to address financial insecurity and inability to pay for food. The control group gets food delivered. So we're still addressing financial insecurity. They get to get their food of their choice. So I think there is a chance here that both groups can improve. And that's the risk of the study design, of not leaving anybody without anything. I will say we've recruited 40 participants so far. We looked at the first 20, not at health effects, only to see if my intervention is working. And we do see an increase in plasma levels of omega-3 in the intervention group. compared to the control group. So we'll see if it's omega-3. We'll be able to, I think, in secondary analysis, try to address whether it's the actual omega-3 intake or whether they were just able to get food that they were not able to get before. And we are focusing here on low-income COPD patients. So I will conclude by saying the cardiologists do it, the endocrinologists do it, the renal docs do it. They have this holistic approach. No one talks to you about atherosclerotic disease and just tells you to take a lipid lowering drugs or go get a cath, right? They talk to you about life's essential 8. These are AHA things that I pulled out this morning. 10 ways to improve your heart health. Here's chronic kidney disease talking about, hey, eat more, such a protein, eat less salt. And then the lung doctors always say is quit smoking and here are your inhalers. This is a call to me to say, look, we have to take a more holistic approach to lung health like the other specialists do. So in conclusion, where you live matters. It's not easy. It's not one thing. So excuse me for the myriad of exposures that I think are contributing, but I do think it is a myriad of exposures. And if we ignore those exposures, we are limiting our opportunity to do something about it for our patients. I believe that these exposures is a large part of what's contributing to both ethnic and racial and socioeconomic disparities in COPD, or at least provides us a window of opportunity to identify ways that we can minimize those differences. I want to close with one more slide. My road was a windy one, right? I said I didn't get too much into it, but my career started as a first-year fellow. I did tuberculosis work in quality of life. And then I started doing asthma genetics. And then I started doing environmental exposures and asthma. And now I do COPD environment. That's really been my focus, but have become more recently super enthusiastic or about the opportunity to identify what neighborhood factors or even food and taking this more holistic approach to lung health. But I don't think I would have had the courage to make those changes in my career path without mentors that supported me along the way. I walked into Cindy Rand's office one day when I was in the midst of writing my K award for asthma genetics, which did get funded, and I did do my K on asthma genetics, but I clearly I think I would have failed, right? I would have not done academic medicine at some point if I had continued down a path that didn't inspire me to wake up at night, in the morning to pick up an article and read about it. And she told me that that was okay, right? My mentors aren't going to be mad at me, that I needed to be true to myself and that my mentors were there to support me. And to Bob Wise, who I was like, gosh, I'm really fascinated by this environment, but is anyone else going to be interested in that? I was you talked to someone, who cares about the environment? It just wasn't the sassy, exciting area of research to many people that I talked to. And so I was scared to embark. Is anyone going to give, support me to do this research? And Bob Wise took me out to lunch one day, which was amazing in itself, because I was a early faculty or senior fellow at the time. And the one line he told me that just resonated and stuck with me was, do what you love and the rest will fall into place. And to that is probably something I say to every mentee. If you have a passion for it, believe me, somebody else does. And to be successful in academic medicine, or to have 20 years of funding, right? It's not about me, it's about all of those people who do the work with me, but it's really about having the energy and excitement to wake up and think about it and to do it and to sell that passion to others. So thank you to my mentors who still mentor me, even though I'm in chair of medicine. I still call them on a regular basis for different questions right now, maybe. And thank you to the team of trainees, colleagues, and mentors that worked with me. And I'm happy to answer questions.
Nadia, that was great. Do we have questions from the audience? I'm going to go to Mark Ernest first, because he just got back from Italy.
Thanks for a great talk. I'm curious that in your data you showed, it looked like there was consistently a difference in indoor particulates between urban areas and the rural areas. And is that purely a function of what the ambient air outside the house is, or what's going on in the homes that's different that would explain that?
Yeah.
And my second question, you didn't mention anything about like HVAC systems that so many homes have, and does that have any impact on indoor air quality?
So fabulous question. So I would actually say it's not due to the ambient air quality, right? And so we look across the US, I would say on average, the ambient air quality it definitely contributes some, but it's not the largest proportion of what's contributing to indoor air here. It's really indoor sources. And that varies by geographic region, right? So we did a study in Peru, an asthma study was my first RO1 ever. And I wrote this indoor air grant based on all this stuff I did here. And then I went to Peru and I'm like, well, that was dumb. Like everybody has their windows open, right? We did a little pilot of the first 50 homes, and like indoor air was almost the same as outdoor air because there was so much more ventilation that was ongoing. So in some areas, the indoor air pretty much equals outdoor air. But in the US in general, particularly in urban areas, people have their windows for the most part closed. So it really is about all of the indoor sources. And what I also didn't show, if you go to suburban Baltimore versus inner city Baltimore, the suburban home levels are much lower compared to the inner city homes. And it's like they're larger, they're spacious, they have HVAC systems, right? And so they have less activity, fewer people living in the house. Whereas you go to Baltimore City, you don't have the HVAC system. You've got 6 people living in a small row house, right? Like there's so much different activity patterns. And so the portable air cleaners did still work in homes that reported to have an HVAC, but it does not mean that the HVAC system doesn't work. It's like if there's still an opportunity to measure that you have particulate matter in the house that's measurable, I think getting it to a lower level, if you have chronic lung disease, can probably still be beneficial, right? Because if you look at mortality data from ambient pollution, it really suggests that a very steep part of that curve is at those low levels of PM. And then you start to get a little bit of plateau where higher is still worse, but it's you go from 90 to 80 on PM is not the same as going from like 15 to 5, right? And does that answer your question? Yeah, thank you.
Nadia, congratulations on some really important work. It's clear from what you presented that it's an incredibly complex series of exposures, lifestyle issues, socioeconomic status, what you eat, where you live, et cetera, et cetera. Put those risk factors in the context of the 2 other risk factors for COPD, genetics and smoking. So if you just thought of it as 3 composite risk factors, smoking, genetics, and this very complex composite of interactive and overlapping risk factors, what's the percent that accounts for COPD?
I don't know the answer.
And then I have a follow-up question.
Yeah, oh, so that's a fabulous question, and I don't have an answer to it. So I think it would be something that we should look at. I really don't know.
And what's the, related to that question, what's the unaccounted risk for COPD? How many people what percent of individuals get COPD and we just say, we don't know why they got COPD?
So I would say that proportion is high, and it's because you have like if you get 1 in 4 Americans have COPD, they never smoked. We don't know why, right? So that's already 25% right there. The thing that also is, it's that degree of severity of the disease that we really don't have a great job of explaining, right? So and I do think some of that is we just don't measure smoking well. I think that's part of it, right? When did you quit? When did you start? On average over your life, how much did you smoke? I just don't think we get at how much people have really inhaled in terms of cigarette smoke. But I'll come back to you on those 2 questions because I think that's part of the next step. We started to started to work with my biostatistician of trying to create this like environmental risk score to say how much of your variability in FEV1 or in risk of COPD can we explain by the environment. So we're starting on that. But your question of adding in the genetics and adding in the smoking and to get a composite risk score, I haven't done that yet. I would think we might get to, I don't know. I don't want to take a guess, but 50%, right? Because there's all these early life factors too, of where did you get your peak lung function, right? So it's not just where you are at the age of 60 or 70. And so we're even, when we're looking at where are we today, like all of these studies looked at sort of historic addresses over the last 10 years. But we're not capturing what happened from 0 to 30, right?
Nadia, thank you so much.
Yeah.
That was a great talk, and I really appreciate you being our NEF lecturer.
No, thank you so much.